Hello, students. Welcome to Concepts of Care for patients with problems of the biliary system and the pancreas. So we're going to talk about pancreatitis, cholecystectomy. Also, we're going to discuss different concepts like cholelithiasis, icterus, we know that, jaundice, and steatorrhea, the Whipple procedure in future diseases in this chapter, okay? So the first one is going to be cholecystitis, okay? So the priority concept for this chapter is inflammation. Then the inflammation concept exemplars for these chapters are cholecystitis and acute pancreatitis. We're gonna talk about pain and nutrition. The first thing that we need to pay attention is that the liver, gallbladder, and pancreas make up the biliary system. So the three of them, the liver, the gallbladder, which is the little pouch under the liver, and the pancreas make up the biliary system. Let's remember that on the right upper quadrant, we have the head of the pancreas, we have the curvature of the duodenum, right? And we have the big part, the most of the part of the liver, and also the gallbladder. So the biliary system secretes enzymes and other substances that promote food digestion in the stomach and the small intestine. When these organs do not work properly, adults may experience impaired digestion, which can result inadequate nutrition, right? Disorders of the gallbladder and pancreas may extend to other organs because of the close anatomic location of these organs, and that's good to know. Pay attention to pain in other organs close to these structures that we are going to discuss. Inflammation and obstruction, blockage, can occur in the biliary system from gallstones, edema, stricture, and tumors. These problems frequently cause the patient to have moderate to severe acute or persistent abdominal pain. Cholecystitis. So let's start with a video with cholecystitis so we have better understanding and the whole picture, okay, from the symptoms all the way to the treatment. Cholecystitis.
Acute cholecystitis is defined as inflammation of the gallbladder. Major functions of the gallbladder are to store excess bile and concentration of bile. Bile is produced in the liver and has many important functions. Some of them include facilitation of lipid digestion and absorption, excretion of bilirubin and excess cholesterol, and neutralization of the acidity in the duodenum. Bile consists of about 95% of water, in which are dissolved a number of solid constituents, including bile salts, bilirubin phospholipid, cholesterol, drugs and their metabolites, and other compounds such as amino acids and enzymes, vitamins, and heavy metals. The most common cause of acute cholecystitis is gallstone disease. When gallstones get lodged in the cystic duct, it causes gallbladder wall irritation and damage when the gallbladder contracts, which leads to gallbladder inflammation, giving rise to the signs and symptoms of acute cholecystitis. In addition to inflammation, there is gallbladder distension, and the pressure within the gallbladder is also increased. This will facilitate bacterial growth, especially the E. coli bacteria. A minority of acute cholecystitis cases can occur without gallstone disease. This condition is called acalculous acute cholecystitis and is associated with gallbladder stasis and ischemia. It is mainly seen in critically ill patients who are hospitalized and on prolonged immobilization. Risk factors for developing this condition include sepsis, diabetes mellitus, immune suppression, cytomegalovirus infection, total parenteral nutrition, major trauma, and burns. Predominant symptom in acute cholecystitis is right upper quadrant pain, which begins in the epigastrium and then localizes to the right upper quadrant. The pain often radiates to the right shoulder. It is a constant pain, lasting for more than 6 hours. The pain is associated with other symptoms such as nausea and vomiting and fever. In addition, patients may have a history of gallstone disease. Physical examination findings include right upper quadrant tenderness and guarding and a positive Murphy's sign. This sign is elicited by deep palpation of the costal margin in the right upper quadrant while asking the patient to take a deep breath. The pain in acute cholecystitis forces the patient to stop breathing. Additional findings may include a palpable gallbladder and jaundice. Diagnosis of acute cholecystitis can be made with clinical features and investigation findings. The single most useful investigation for the diagnosis of gallstone-related disease is abdominal ultrasound, which may reveal gallstones in the gallbladder and inflammatory changes such as gallbladder wall thickening and pericholecystic fluid. In addition, blood tests may show moderate leukocytosis. C-reactive protein levels may also be elevated. And marginal elevation of serum bilirubin, alkaline phosphatase, and aminotransferases may be seen. Finally, the treatment of acute cholecystitis can be divided into conservative management and surgical treatment. Surgery is usually delayed for a few days until gallbladder inflammation settles. Conservative therapy includes intravenous fluids, pain relief with analgesics, antibiotics, and bed rest. The definitive treatment of acute cholecystitis is surgery to remove the gallbladder, which is known as cholecystectomy. This could be either open cholecystectomy or laparoscopic cholecystectomy.
Thank you so much. So basically, there you go. You got the entire picture of cholecystitis, including cholecystectomy. So now we're gonna get deep into the concepts, especially nursing care, which is the main reason you are studying this, right? How you are going to prepare the patient, what are going to be your advices, and what is going to be the nursing care post-operative, okay? So we have two types of cholecystitis. Let's review the calculus and acalculous cholecystitis, right? So the most common type is calculus cholecystitis, in which chemical irritation and inflammation result from gallstones or calculi, cholelithiasis. Calculi is called cholelithiasis. Cholecystitis is the inflammation of the gallbladder, and cholecystectomy is the surgery. Okay, don't get confused with the terminology. So these calculi that obstruct the cystic duct, most often gallbladder neck, and common bile duct choledocholithiasis. Okay, so basically the exact mechanism of gallstone formation is not clearly understood, but abnormal metabolism of cholesterol and bile salts plays an important role. I would say that everything in excess causes problems. So if you are eating excess quantity of fatty foods, right, this is going to overwhelm the biliary system. So in order to find the real reason why your body is not processing this high amount of fats, then you have to eat regular, normal, okay? Not minimum, not too much, but just moderate. So here we have the graphic. You have the liver, the gallbladder, the cystic duct. Remember, the cystic duct is related to the gallbladder. And then we have here this tube in the middle, which is called the common bile duct. And in this tube, we are receiving the bile coming from the gallbladder. We are also going to receive hepatic enzymes from the top, and then this tube is gonna meet the duodenum. Notice that here we have another tube, which is the pancreas. Is the pancreatic tube, right? So the pancreas, the gallbladder, and the liver are sending enzymes to the common bile duct, and this is going to ended up sending all those enzymes into the duodenum through the sphincter of Oddi. Here there is the sphincter of Oddi, okay, which is another reason sometimes why this biliary system has problems. There, like the same way we have the lower esophageal sphincter between the esophagus and the stomach, the sphincter of Oddi here plays a role between the common bile duct and the entrance to the duodenum. Okay, so gallstones are composed of substances normally found in bile, right? Such as cholesterol, bilirubin, bile salts, calcium, and various proteins. So I think we understand the participation, the purpose, and the role of bile. However, I want you to refresh your knowledge. I'm sure you already know this, but I want you to refresh your knowledge about bilirubin. It's very important because it participates in different organs.
Hello, in this video we will study about the bilirubin metabolism. The bilirubin metabolism begins with the red blood cells, which have a lifespan of approximately 120 days. And after they complete their life cycle, they are destroyed in organs like the spleen and the liver, which contain numerous macrophages. So it releases the hemoglobin within the red blood cells. The hemoglobin is then split into the heme component and the globin component. The globin is further converted into the amino acids and utilized in the body. The heme component is then converted into the iron and the biliverdin, and this reaction is catalyzed by the enzyme heme oxygenase. In the next step, the biliverdin is converted into the yellow compound, the bilirubin, and this reaction is catalyzed by the enzyme biliverdin reductase. This bilirubin so formed is it in the unconjugated form, which is not the water-soluble form. So it requires albumin for its transport to the liver. In the liver, the bilirubin is converted into the conjugated form, which is the water-soluble form of the bilirubin. And this reaction takes place by the combination of glucuronic acid with unconjugated bilirubin. It is then transported through the biliary channels into the duodenum, and through the duodenum it reaches the colon. In the colon, the bilirubin is acted upon by number of microorganisms and is converted into urobilinogen and stercobilinogen. Majority of these compounds are excreted in the feces in the form of stercobilin, which imparts yellow color to the feces. But 10 to 15% of these compounds are reabsorbed into the blood, and some part of that reaches the liver, and this is known as the enterohepatic circulation. A few percentage of the reabsorbed compounds reach the kidney, and they are excreted in the urine in the form of urobilin. So this was a brief overview of the bilirubin metabolism.
Thank you so much, Dr. Matalana. This is too complicated. I cannot remember all those terms. The most important is that you remember that the bilirubin is caused by the breakdown of the red blood cells, right, in its component called heme and globin. So then there is a part before getting all these waste and metabolism products that is going to be unconjugated bilirubin that happens before the product enters the liver. Once it's in the liver, it's going to be called conjugated bilirubin, and that bilirubin is going to go through the biliary system. Okay, then it's gonna enter the duodenum, the colon, and then some is gonna go back to the liver through the enterohepatic circulation, and the other one is going to go to the kidneys. So then we have the activity of bilirubin is gonna go from the liver to the biliary system, then to the small intestine, the colon, going part of that back to the liver, and then it's gonna go the other part through the kidneys. You see, there are many players in the bilirubin, and this was a good refresh. Probably you are not gonna capture everything right now, but little by little with repetition, as I always say, repetition, okay, is gonna make you understand, and it's gonna make you process the knowledge. It's very important. So then we have that the gallstones are composed of substances normally found in bile. We know what is bile, such as cholesterol, bilirubin, bile salts, calcium, and other proteins. They are classified as either cholesterol stones or pigment stones, okay? Now, cholesterol stones form as a result of metabolic imbalances of cholesterol and bile salts. We know that. They are the most common type found in adults in the United States. Bacteria can collect around the stones in the biliary system. Severe bacterial invasion can lead to life-threatening suppurative cholangitis. When symptoms are not recognized quickly and pus accumulates in the ductal system. So cholangitis is defined as the inflammation or swelling in the bile duct system. The bile duct carries bile from the liver and gallbladder to the first part of the small intestine. You see, it's repetition, repetition. With more participants, I keep repeating and I keep reinforcing your knowledge. So we have the liver, we have the gallbladder, and we have the cholangitis, that is defined as the inflammation or swelling of the bile duct system, okay? And this is mainly caused by bacterial infection. Good. So now we have acalculous cholecystitis, which is the inflammation occurring without gallstones. It's typically associated with biliary stasis caused by any condition that affects the regular filling or emptying of the gallbladder. Biliary stasis, please understand, is when there is like something is paralyzed, right? So there is a stasis caused by any condition that affects the regular filling because it's not working properly, or emptying, either the entrance or the exiting of the in the gallbladder process. We have the sphincter of Oddi, as I mentioned before. The dysfunction can also occur to cause reflux, and we know we studied the GERD, right, with the lower esophageal sphincter. This is the same thing. The sphincter of Oddi can cause reflux and inflammation, right? So it's not entering the duodenum, so it's going to go back into the biliary system in the common bile duct. Most cases of this type of cholecystitis occur in patients with sepsis, severe trauma or burns, long-term total parental nutrition, the one that is given through IV, through the circulatory, right? It's not the enteral, right? We know that. Multiple organ dysfunction syndrome, major abdominal surgery, and hypovolemia. Okay. So chronic cholecystitis. Now from acute, we are going to chronic. Most often happen when repeated episodes of cystic duct obstruction cause chronic inflammation, and calculi are almost always present. So this is a patient that had gallstones, right? And there is an obstruction in a bile duct and common bile duct, and then the patient solved the cholecystitis by normal, maybe correcting the diet, treating the pain, and then the person gets very nice diet, and then is having a recurrence and back to normal, and then another recurrence. So this becomes chronic. cholecystitis. Young thin women, especially those who are athletic, pay attention to this because this is very important, especially with all these new diets going on right now. Young thin women, especially those who are athletic, may experience chronic cholecystitis without calculi. Dr. Matlana, what is this? I don't understand. If these are athletic, they are healthy, they are not eating that much cholesterol, what's going on? In this case, the gallbladder atrophies and causes pain that is often misdiagnosed with gastritis. This problem is most likely to occur when consuming a diet low in fat, such a vegetarian diet. Now I am so confused, Dr. Matalana. Acute cholecystitis is because you eat too much fat. Right now, these girls are having chronic cholecystitis because they are consuming a diet low in fat, and on top of that they are vegetarian. Okay, so this is the thing. When people are losing weight fast, okay, as the body metabolizes fast during this rapid weight loss process, it causes the liver to secrete extra cholesterol into bile. Do you remember I told you before the stasis, it's like there is no activity? So when the person is losing weight, is practicing too much sport, is not eating a lot of fat, the liver is going to secrete extra cholesterol into bile in order to have the gallbladder and the entire biliary system to be working. Okay, so they don't get into strike. Well, we are in strike because we don't have nothing to process. Okay, so the liver is going to secrete extra cholesterol into bile, which can cause gallbladder. Fasting, listen to this, fasting decreases gallbladder movement, which causes the bile to become over concentrated with cholesterol. So when you are doing your fasting, you're 18, you're 16, 8, and you think you are getting really healthy, okay, you need to monitor yourself. I actually have a case in my family. Somebody was fasting. I shouldn't be mentioning this because I don't want to motivate you to do this. But this person was desperate because she was having a history of cancer in the gastrointestinal. I don't want to give more details. So she recovered from this, and then she was trying to make fasting in order to avoid a recurrence. So instead of doing, she started with 16.8, and then she increases to 24, 36, 48, 72 hours fasting. Eventually, she was losing weight. Her numbers were getting better, but suddenly, from one day to another, she developed this cholecystitis and she had to get a emergency surgery. Okay, so what happened is that the gallbladder was having bile very concentrated with cholesterol. On top of that, besides doing the fasting, this person was doing the ketogenic diet that we know is high in protein